Grazie, Mario. Well, these are my only biometrics is related with this talk. I will not bother you too much because yesterday we were focused on the MEC. As you know, there are clear advantages above other procedures. All of them works fine in hands of experienced surgeons. But one of the problems, as I mentioned yesterday, that we had in the beginning with the MEC is the number of rebubblings. And as you know, several tricks has been apported by different surgeons. The one that we used, as I mentioned yesterday, is the use of gas. So together with a wide host descematolrhexis, I think that for the MEC it's important not to have overlaps. The rate of rebubblings is higher when you overlap your donor and your recipient. So not use viscoelastic, and if any, as we mentioned yesterday, use cohesive and not dispersive. I don't like to use any, particularly. And we have been working, as some other groups after us, with tamponade with 20% SF6, because then we allowed to have a bubble inside the eye for 4 or 5 days at least, and we can play with this bubble, as I mentioned yesterday, with this positioning for the first week post-op. It's a kind of constant rebubbling for 3 or 4 days. But of course, so this was the technique. You saw it yesterday. So basically the technique was to use air to position the membrane over the iris, and then to use SF6 20% underneath now to push it up. So this was basically the technique. As I mentioned yesterday, the technique changed a little bit in 2010 towards a non-use of air in front of the membrane. So this part is the same, but once we have the roll inside the anterior chamber, we only use touches over the cornea and injection to position the fluid, no air, but we keep with the use of 20% SF6 because we think, we are completely sure that the rate of rebubblings is very low. So there were some concerns regarding the toxicity of SF6 on the endothelial cells. And as you know, if you look to what has been published, you can defend one option or defend the other option. Most of the studies shows that toxicity to the endothelium or to the retinal cells coming from the use of gases are because of the tension and not because of the gas itself. So those cases that has been found to be toxic is because the eye has left with high pressure, both on the retina and in the endothelium. And the same for blues. There are enough studies showing that most blues are not toxic for the endothelium. So anyway, this has been a comparison, and this has been accepted, so you will be able to see all those figures. And so I will not bother you too much with numbers. Comparing our experience, these are 42 patients in group 1, where we use SF6 as tamponade, and 39 patients in group 2, where we use air as tamponade. So as you can see, the distribution of patients is similar, both in age, in gender, and right and left eyes, and also in the indication. Because as you have seen, although most were Fuchs, about 30% in both groups were pseudophakic bullous keratopathy. Pre-op conditions are, from a visual acuity point of view, were similar, as well as the donor central cells were also similar, with a mean of 2,500 and 2,400 on the group 2. So this is cumulative visual acuity in the group of 20% SF6 and 100% air. So no significant differences, as you can see in this distribution. This is the stability of the spherical equivalent in both groups and the cylinder. Again, because the technique was the same, and the only thing that we changed was the tamponade was quite similar in both groups. And these are the central corneal endothelial counts with their respective standard deviation. And again, no differences, no statistically significant differences in this 3 years follow-up between both groups, those where we use 20% SF6 and those where we use 100% air. So in summary, as I mentioned yesterday, the bimanual infusion technique, inferiorudidectomy in transitory 20% partial tamponade allow us to significantly reduce the intraocular membrane manipulation time, which, on the other hand, yesterday, Terry, Mark, demonstrated that it's not a significant issue for trauma to the cells, but I think it's a significant issue for trauma to yourself. If it takes 1 hour to position the membrane, the next surgery will be not very nice for you. Possibly you will go back home until the next day. So anyway, you reduce the manipulation time and you reduce the post-op rebubbling rate. Our 3 years shows no differences. Of course, always that we mention cell counts, we know the limitations of cell counts. And at least I am quite aware that these studies will be more powerful once we have a lot of numbers and another strategy to count cells. But the way that we count cells today, no significant differences between both procedures. Thanks very much for your...
Congratulations, Jose, great talk as usual. I think the major issue is improving the attachment rate. So that's a critical point. Thanks again.
Thank you, Mario.
Vincenzo.
And let me just say thanks very much, Professor San Nicola. This is my last talk. It has been a pleasure, as always, to be with you here. I've been since the beginning. I think that that's the best, as you know, meeting in cornea because of the combination. No, I'm serious. I think that we started with Eucornea, but copying your meeting, so hope that we will continuously work together.